All right, we'll go ahead and get started. Thank you for joining us today for this episode of our Pediatric Tech Talk. And I'm Leanne West. I'm Chief Engineer of Pediatric Technologies, and I'm your host today. I am going to be talking to Michelle LaPlaca about her research in neurotechnological innovations for the clinic. And Michelle, I would love for you to introduce yourself.
Hi, sure. Thank you, Leanne, and the Pediatric Technologies group for inviting me today to talk. It's really a pleasure. And so we're going to be discussing, some of the work that I'm doing that's clinically translatable. So we're doing some clinical trials, but it's not yet in the clinic, and just about some of the challenges there. But my basic research program, it's really clinically, it's translational. So I have a preclinical component that we really look at biomarker discovery, as well as investigating different fluid flow patterns in the brain, basically to see how biomarkers move around in the brain and how the brain is affected after injury. So really more on the preclinical side, so things that are pretty far away from making it to clinic, and then also work on more applied research, such as what we're going to talk about today, multimodal, tools, assessment tools for concussion. And just in general, I'm very interested in, how we get our basic findings to the clinic. So that's just in a nutshell.
That's wonderful. All right. So I know we're going to talk about concussions. How do they happen and who gets concussions?
So they can happen in lots of different ways. So focusing on kids, because we're talking about pediatrics mostly today. So young kids get concussions and brain injuries from falls, as well as just getting either struck with an object in the head or having their head strike an object. So things like, hitting a table, a toy. And then as we get older, we have a higher risk factors, as we go out into the world. So for older children, it's motor vehicle accidents and still falls. And then also just recreational, a lot of things are just grouped into sports related or recreational. And then in our very young, we do also have abusive head trauma, which is, it is a way that kids can get head injuries. So I don't want to leave that out because it's very important. And so those are just different ways. As we get older, there's also just a peak in young adults that for also motor vehicle accidents and falls and recreational activities. And then we also have another peak in incidents in the elderly as well. So it is something that can happen to anybody at any age. So that's why and there's so many variables that go into how you respond. I think that's why we have so much interest around it. And it's, just a very important, thing to look at clinically.
Definitely. Because I know there can be long-term effects from concussions as well. So super important to catch them early. So why do we need technologies to help us diagnose these concussions?
So it's an interesting question, and just to follow up on your last point. So, for mild traumatic brain injury, most people will recover, within a couple of weeks. But what we're very concerned about, and what clinicians are concerned about, is that, at 1 month, and 1 year, we still have some persistent symptoms. So, you have, a third of people, and it varies depending on what age group you're talking about, would still have symptoms at a month. And then, you might have kids, 5-10% of kids that have had a mild TBI still need school support a year out. So you can see how this could just affect, like you said, people in the long term. So as far as diagnosis goes, and I just want to preface this by saying I'm not a clinician. So I collaborate with clinicians, but and we work very, very hard to understand the clinical workflow, which is, I think, important for everybody working in this space. So basically, depending on if a incident was seen by somebody. So, they go by observation, especially with kids that would want to find out what happened, like what's the mechanism. Was the child belted in or not belted in, or so on? How high was the fall? Because that can tell the clinician just what if there's other risk factors there. For example, if it was a high speed crash or a high fall. So you're going to go on just your general symptoms. If a child can describe their symptoms, or a parent or a caregiver can describe symptoms. If there's any physical, I mean, the thing about concussion is there's not a physical mark, right? So you can't tell on imaging if somebody's had a concussion or not. So that's one of the things that pediatricians and people who care for kids are very concerned about, is that they not get CT scans unless there's some other risk factor where there's an indication where they might have some intracranial or some abnormal finding inside the brain. But typically you wouldn't want a kid to have an X-ray or a CT scan if it's a concussion. And then there's just different validated tools that are used by pediatricians, sports medicine providers, sometimes and nurses that go into that decision-making process.
All right. So how about telling us a little bit about the device that you're building and working on?
Sure. So we are working on a device that we call Detect, and for kids we call it P-Detect, or Pediatric Detect. And it is a VR tool. So it's virtual reality. So we have deduced, and this is in collaboration with others. So it's not just me. I just want to mention David Wright in emergency medicine, Rusty Gore at Shepherd. And then I'm currently working in the pediatric space with Rob Grell, who's a pediatric resident in emergency medicine and pediatrics at Emory and Children's. So it is taking tools that are used, that are validated, so certain neuropsychological tests and also oculomotor tests and balance. And we put it into like a game, in a virtual reality game. So for the kids, it's a carnival. They go around from station to station in the carnival playing these different games. So for example, we give them a set of words to remember, and then we present them with those words as well as some distractor words, and they have to tell which word was there in the beginning and which wasn't. So whether they can remember that list of words, and then we do it again later to see if they've remembered them. So it's very similar to some of the tools that are used in athletics or at the pediatrician's office, remembering words, things like that.
Very, very cool. I love that you're making it more game-like for some of the kids to do. I think that always helps. And you mentioned like football sidelines, doctors. Is this something that you could see being used like that, like on site when a kid might experience a concussion?
Yeah, no, that's a really good question. We get asked that a lot. So, when we first developed it, there really weren't any sideline tools for concussion, and we were looking primarily at college age and high school age athletics. That was our target audience. We've since have expanded down to younger kids. So it really depends on the situation. So in many situations where you have like an organized sport, and so for college, I'll just start there and go backwards. So in college, most athletic programs will have an athletic trainer on the sideline. They'll have some kind of medical staff that's trained to diagnose concussions, or to at least look for things that might be a concussion, and hopefully sit the players out if there's any suspected concussion. And there, when you have a high level program, then they're going to be very experienced at that. And then as we move further down into less and less organized or less and less resources, then so some high schools, for example, would have an athletic trainer on the sideline, might have a volunteer doctor on the sideline, whereas other high schools won't have anybody, except for at certain sports like football, there would be an EMT that was nearby. And then, when you get down to, the recreational, leagues, town leagues, church leagues, usually there's nobody there that can diagnose, right? So you have to rely on, the parents and the coaches. And so, for example, like CDC has put out a lot of educational tools to help people learn how to recognize and when to bring, a child to the doctor, or at least look for some signs. So there's more and more educational resources that have gone out there. So I guess to go back and answer your question. So it could be used on the sideline. What we envision having is a shorter version that would be able to be used right there. And we don't want to replace, if there is an athletic trainer or somebody that's, we don't want to replace them, right? We just want to give them additional tools that they can use. So it's more for the hard to decide cases, or if they're unsure, so for things like that. But we also want to be able to have a longer version that can look more into the different types of concussion, because that's one of the things. I mean, it used to be years and years ago that we were just looking at cognitive problems, but we know that there's a lot of somatic issues, there's a lot of physiological issues that you want to keep an eye on. So, for example, some people who have a concussion will have more balance problems, some will have more memory problems, headaches, and these kinds of things. So, I guess the number one thing is you want to make sure there's nothing more serious, right? So you want to educate, on, some of the signs for a more serious condition. And then the other thing is to help make those decisions. And luckily, Georgia and all 50 states have legislation where if there's a doubt, then you sit them out, is basically the kind of the tagline a lot of programs use, right? So that's for K through 12. Programs. So at least that's in place. People are aware of that. And then we also want for return to play decisions. So tools like ours and other validated tools could be used to kind of monitor, like after a clinical diagnosis is made. And concussion is a clinical diagnosis. So you can use tools and tests and symptom scales to help make the diagnosis, but it can't be made by a parent or any one test, right? It has to be made by a clinician. But once that's made, you want to have them in a return to life protocol, right? Return to sport, return to school, or whatever they're aiming for. So we'd like to have a tool that's fun to use that can just monitor their progression, in addition to the other things that parents are looking out for and things like that. So we think that it could fit into many different places.
Yeah, definitely. And so I know you're actively taking data to kind of verify that everything works like you think it should. Can you tell me a little bit about what you're doing?
Sure. So we're working with, actually, I have to give credit where credit's due. So with Claudia Morris and Rob Grell in pediatrics, and Rob, like I said, is a clinician and working in the emergency department. So what he's doing is, once they have the intake of kids and they're waiting for results or waiting for, just waiting around with the parents to kind of monitor, they're enrolling in the study and taking this test, which takes about 10 minutes to take. And so they put on the goggles, and usually kids are really willing to try out VR, and they're very familiar with putting a headset on and operating controls. So that really hasn't been a problem with the kids at all. And then they take the test, and it's not being used for any clinical decisions. It's just being used to kind of see if it can pick up deficits. And then we're also getting the controls also from the emergency room. So it might be a sibling of the kid who comes in, or it might be, an orthopedic injury. So we're taking those controls too. And what Rob has found, he's still analyzing the data, but he has found that the kids that have a clinical diagnosis of concussion, they have deficits. And what we're focusing on now is the oculomotor test. So basically in the ability to be able to time and to plan eye motion. So they have to follow a track. It's actually the kids version is it's a pie. That's a clown that moves, and they have to throw a pie at the clown and hit the clown in the face. And the clown moves at different speeds. And so they have to basically time. So you can you can really access kind of the neurological pathways that are associated with vision tracking, and timing. So we were pleased to see that there was actually, and it's interesting because for the kids versus the older, like college age, we actually found more deficits in the children, and it's different cohorts of patients, so they're not directly comparable, but it was just interesting that we were able, it was sensitive to pick up deficits. So his study is coming to a close, and he has 100 subjects in it, so we have a good amount of data that we'll be following up on, and he'll be publishing that. So that's really exciting to see. And it's interesting because in the emergency room, it may not be where it ends up, because clearly the emergency room is not meant to be a place where you're doing a lot of concussion care. So for example, in a busy emergency room like Grady, you really wouldn't have a place for a tool like this, because they're trying to really triage and just look for the life-threatening patients that come in. And same is true for the pediatrics, but they found for the study that they actually had this time where patients were and their parents were waiting around, so it worked out. But ultimately, that could then be transferred to a pediatrician's office, a neurologist's office, for example, where it's a little bit more of a controlled environment.
Yeah. Okay. That's great. That's great that there's so many places that it could fit in to help with this problem. So your device sounds really cool and awesome. Does the FDA need to approve it or do anything with it? What does that look like for you working with the FDA?
Sure. So we have talked to the FDA, and the goal would be to have it be cleared as an aid for diagnosis. So what it looks like now for concussion is there's approximately 8 devices or methods that are cleared for use to aid in the diagnosis or management of concussion. So basically that's just to emphasize that it's not a diagnostic test, it's just an aid. Yep. So basically they have just asked a lot of questions about the test, where did they come from, where do we know that the eyes are moving, was one thing that they're very interested in. So we're talking with some eye tracking experts in terms of trying to match up what we're having the subjects do and what their eyes are actually doing, because 2 of the devices that are cleared are eye tracking devices actually, so we know that the FDA really has their eye on this. But not a lot of them are cleared for pediatric use. So that's definitely something that the FDA is going to go very slowly on. There's a neurocognitive test that's approved for pediatrics, and also some prevention tool that goes down to age 13. But rightly so, the FDA is very careful when it comes to clearing these things for pediatrics.
Yeah. Okay. I think that it's so needed in the pediatric space, though, with the injuries that kids can get. Mm-hmm. So what else needs to happen with this device before it can be start being used in the real world?
So in addition to using the FDA feedback to guide studies, we would need to do many more clinical studies in different environments, focus on, whether we want to continue in the emergency department, or if we think that the next, set of tests would be better in a different environment. It needs to be compared more carefully, like a, one-to-one with some of the validated tests that are being used clinically. So that's really important, and the FDA will want to know that. And since it's even though it's based on existing tools, it's still something different, right? So we would have to, collect normative data. So basically test, lots of kids just to kind of see what the range is. And we are very aware that, kids change as they get older. So it's not a one size fits all, because development is it has large ranges. So we would like to be able to make it more flexible and adaptive to account for, kids over, a range of developmental stages. So that does take a lot of work to get all that normative data. So that's one thing that we really would like to do, and also maybe, make the carnival look a little nicer.
Nicer carnival is good.
Yeah.
And so for the normative data, you're really talking about kids who don't have a concussion or aren't suspected of a concussion, right? It's really, what is the average child? How do they perform on this test?
Correct.
Yeah. Okay.
Mhm.
All right. What about, since this is a virtual reality technology, what else can something like this be used for? Like, are there other things? I mean, I know I've heard about it for kids who are maybe going to undergo a procedure and you're kind of trying to distract them, or to lessen the pain by distracting them, to lessen the anxiety. Anything else that you can think of?
Yeah, no, it's a really interesting time, because as virtual reality gets cheaper to have, these sets, so it has been used for, kids, like you said, getting either a shot or getting an IV put in or before a treatment. It's been used for, it's sort of, distraction, or just to reduce their anxiety levels, to put them in a more, a environment like that. So it can be used for, rehab, for example, is one use if you wanted to teach skills. It could be used in education, and I'm sure there are, VR tools in education. I'm sure of it. But as far as medical use, I think, especially with kids that are more comfortable with these types of tools, I think there's really a lot of different possibilities, for, ADHD and, managing pain, and even for, educational purposes, medical educational purposes, like teaching them, like, why, a cancer patient, why, what's going to happen to them, MRI, so if it's very claustrophobic, you don't want to be, putting kids under anesthesia all the time. So there's been some research into, can you get them comfortable with that environment ahead of time with the VR space, and then they won't be as anxious when they go into the magnet. So I think there's lots of uses, for VR.
Definitely. And I mean, some of them are kind of fun, since you can make games out of things for the rehab and the distraction and such. So I think that's really cool. We do have a question in the chat, and the question is, how big is the problem of concussion in K-12? Is it escalating, declining, staying about the same?
Oh, that's a very good question. So it really depends on what you look at. So there are if you look across time, they're increasing. The numbers are increasing. That the numbers that go to the emergency department for concussion or head injury related things, hospitalizations have increased. So there's a lot of things that have increased, but it's also clouded by the fact that there's more awareness, for concussion. So it's really, it's an interesting problem to tease apart whether it's the actual incidence that's increasing. And certainly then we have the stay-at-home COVID blip in there. So the epidemiologists are paying, a lot of attention to that, and what that means in terms of kids getting more injured at home, for example.
Oh yeah, okay. I think the COVID gap gives a lot of opportunity in a lot of different areas to kind of see how things are working. So another question in the chat is, are there any commercial pediatric EEG or concussion detecting wearable devices? Do you know about anything like that?
So I know that, BrainScope is one of the FDA cleared EEG wearables. It's not really a wearable, it's a test that's done, clinically. And I know that they are researching a pediatric version. As far as I know, it hasn't been FDA cleared, but I don't know the status of that, but I know that they're interested and they've applied for that. So yeah, so I think as EEG, you can get smaller and smaller, for example, and there's more and more, advances in microelectronics and things. So I would expect there to be more wearables. We have to be careful in, outfitting, kids with wearables and then using that to diagnose, right? So I think the wearables have a lot of advantages, but we also have to be really careful about, consumer use and, are they sensitive enough, the tools that the clinician is going to be able to use them? And then we certainly don't want lay people diagnosing concussions. So we just have to be careful.
I would think that if there was a wearable, it wouldn't necessarily be for the home diagnosis, but again, to aid a clinician or the sideline person who's maybe looking at kids, on a football team as they come off the field. I would definitely think of it as an aid as well, as opposed to its own diagnosis entity. We're coming up on time. I wondered if anyone has a final question or two you want to put in the chat, feel free to. But is there anything that I didn't ask you that you maybe want to talk about? Is there anything else you want to say?
Well, no, yeah, we can monitor the chat. I can't see it from here, but I think that it's a really interesting time, and there are a lot of things that are being tried, like blood biomarkers is something that there is some FDA clearance for some biomarkers that they aren't diagnostic, but they can be used to distinguish whether somebody may need a CT scan or not. Those have not been cleared for kids. So I just think, paying attention to more personalized care is something that we're going to see in the future, because there's all different ranges of symptoms and deficits, and it's not just, one size fits all. So it's not as if, you get this score on this test and that means that you're going to recover versus you're not going to recover. And prognosis is very difficult to do, and I think it will always be, but some tools that can help just make the clinical experience more personalized so that we can at least tailor the rehab and the return to life protocols.
I think personalized medicine is really going to be everything in the future, which made me think of another question. Just briefly, I think that for kids, you want to get their normal baseline beforehand, so that if they come off the field after playing football and you suspect there might be a concussion, you can kind of compare it to what their normal is, right? I think a lot of things are kind of moving that direction to understand what normal is for a particular person.
Yes, I think, in theory that is, certainly we see that, right, with the impact test, for example. Actually, the baselines are not recommended by the CDC per se.
Okay.
They don't have a lot of currently. I don't think it's necessarily going to always be that way. But yeah, I mean, because it's very difficult, because in sports you can baseline people beforehand, right? But there's still some problems with the baselining, the conditions that they baseline in versus the conditions that they're in when they have an injury. And then, of course, there's people who aren't in those organized sports. You can't do baselines on them, right? So you would need to have tools that could work without baselining, so that you don't miss, kids that come into the emergency department, or that, don't have those resources to be able to be in a place where they can get a baseline test.
Got it. So there was one more question in the chat, if you want to stay on for just another minute. The question is, what do you need from others? What would be especially helpful to your research? So is there anything that any of us could do to help?
That's a great question. I don't know. I'm not sure how to answer that. I think that, working with clinicians is really beneficial, right? Because we need to know if something has staying power or not, and how we would tweak it. I think that certainly having subject pools and doing human subjects research on kids is challenging, and we want to definitely I would be interested in expanding those studies into similar populations that we're working in now, as well as others. And then from a technical perspective, I think kind of that the analysis of all these data, that's something that we're working with some machine learning folks here at Georgia Tech, but that's kind of the next step, is developing some more sophisticated tools And then just enhancing the user experience and making sure that, and I don't know what that looks like. That might be AR down the road, augmented reality. But yeah, those are some things I can think of.
All right. Well, this has been wonderful. I thank you so much for joining us today. And we look forward to our next Pediatric Tech Talk, probably in February. So keep an eye out. And Michelle, just thank you again for everything. I think this was really, really interesting.
Okay. Well, thank you, Leanne. It was nice talking.
All right. Bye, everyone.
Bye.